So I'm going to talk today about the Tulane experience during COVID-19 for the neurology department and what we've experienced thus far. First of all, our patient population is in Louisiana. We had our first known case that was hospitalized on March 19th of this year with an expanded growth. Many people have said this was due to Mardi Gras being a few weeks before the first presentation of any COVID patients in New Orleans. We rapidly reached our maximum resource utilization by April 1st. And you can see this is the University of Washington data that shows that we exceeded our ICU capabilities around that time. Certainly have had a lot of stressors on the system. From our perspective, we converted most of the hospital to COVID beds. So we had initially started in the neuro ICU, which many places did initiate COVID units in the neuro ICU. So we gave up our unit, sort of moved over to the surgical ICU that quickly became the only clean ICU in the whole hospital, where every other ICU bed was occupied by COVID patients. We also had several non-ICU spaces that were converted over to ICU capabilities to account for the rapid influx of patients that happened in late March and early April. Thankfully, we implemented social distancing, and it certainly reduced the spread of COVID in Louisiana and in New Orleans, and we rapidly saw a decrease. So we're on the path for improvement. During the time of maximum hospital utilization, we changed the workflow of the neurology service. We had goals to protect our healthcare providers, especially our neurology staff. We have limited neurology residents and attendings, so we knew that we had to stay safe or we'd be in big trouble. We also, like the rest of the country, needed to conserve PPE. So we initially implemented that all COVID persons under investigation or positive patients were to be seen only by an attending. And we did this with or without the telemedicine robot that we normally use for telestroke. So we have a pretty robust telestroke program, and we're able to use one of the robots in our own hospital. At some point, I myself was placed on quarantine, and so, and I didn't have appropriate coverage, so I started rounding with a telestroke robot in my own team. You can see this is my nurse practitioner, Olivia Cornu, who was wheeling me around and bringing me in the room, sometimes examining the patient, and if the patient was positive, she would stand outside of the room so she wouldn't need any PPE at all, and our team was able to use 0 PPE for the first several weeks. We also implemented a policy that all EEGs were to be approved by the attending neurologist to avoid tech exposure. Certainly across the country, we have a decrease our need for EEG technicians, and we're no exception. So we decided that all EEGs would be approved by the attending. And then we use Ceribell for all COVID persons under investigation or positive patients to avoid going into the patient's rooms. And in several cases, we combine those technologies of the telestroke robot and Ceribell. So I was going to present some of those cases today. The first is a 67-year-old woman who has multiple medical comorbidities as expected in our patient population. She presented with respiratory failure and was intubated. She was on sedation, as many of these patients have been, but she didn't wake up when it was stopped. So the primary team was concerned that she was having a primary neurologic problem. She was also on a heparin drip for the hypercoagulability that is associated with COVID-19. Given that she was not a candidate for IV TPA, so only interventions that were possible to be treated would be a large vessel occlusion or an ICH, intracerebral hemorrhage. So we were worried about something major happening to her brain. I was able to examine the patient via the telemedicine robot with the nurse's assistance. So she reeled me in and helped examine the patient while I observed. She had non-focal exam. This was a traveling nurse who was coming from another facility, another related facility outside of the New Orleans area, as we had our major influx. And so she didn't know anything about the Ceribell device, and I was able to talk her through attaching the headband and obtaining the data. So based on the clinical exam and the information that we acquired, I thought it was most likely a metabolic encephalopathy, which would be consistent with her other medical conditions. Based on symmetry on her EEG, I decided that we could avoid transportation as she was not likely to have one of these major interventions or major conditions that needed intervention, including intracerebral hemorrhage or large vessel occlusion. So, and that decreased the risk of our staff for transportation and potentially breaking of the ventilatory circuit and exposure to more people to COVID. So we were able to avoid that risk. The following day, she was able to follow commands as her sedation probably wore off and she was back to her neurologic baseline. She was able to talk around the ET tube. So that was one case that we combined technology so that we could avoid additional exposures to our staff and certainly save PPE with that case. The second case was a patient who has a history of epilepsy, specifically post-stroke epilepsy, and she was at what became a makeshift hospital in the Morial Convention Center. Many of you out there have probably been to a convention at this convention center and was converted over to a makeshift hospital during the surge. Originally, it was supposed to house 3,000 patients, but ended up only needing to house about 200, thankfully. So that is also the site of another major disaster in our history, which is during Katrina. It was a place of last resort, a shelter of last resort for those who could not leave the city. And so you can see next to that is a picture of people sort of pouring out of the convention center during the Katrina time. So we've certainly seen a lot of disasters at the Morial Convention Center. So this lady was admitted with hypoxemia and ended up going into hypoxic respiratory failure at the convention center and required intubation at that time. She was transported over to our hospital. We were consulted for altered mental status. She had multiple metabolic disturbances, including a BUN of greater than 100. I saw her in person with this for this case. Her eyes were open. She had a right forced gaze. She was able to follow commands on the right. So I was a bit worried about a post-ictal phase, or was this possibly a new stroke? She did have some left hemiplegia and twitching of her left arm with increased tone. So I was worried about either a metabolic disturbance or a post-ictal phase. So we monitored her on Ceribell as well. We found some epileptiform discharges with phase reversal in the right temporal lobe, which is consistent with her CAT scan as shown. We treated her with anti-epileptics and supportive care for her COVID-19, and she improved initially clinically, both clinically and on EEG. She improved to the point of being able to be stepped down out of the ICU and was on her way to make it into rehab. Unfortunately, as is common and described with COVID-19, she decompensated earlier this week and had delayed hypoxic respiratory failure again and expired after being transitioned to comfort care. So that's some of the experiences that we've had in New Orleans and at Tulane Hospital with our neurology workflow, specifically tying in the use of multiple technology possibilities so that we can better keep everyone safe and preserve PPE.